Unfortunately, the Ca and calcitonin was still elevated, and this was a PET scan, also negative. But the important lesson here is that the surgical management must be good from the beginning. Just a few last slides on thyroid PET scanning. Basically, the TSH increases GLUT1, and we do see about 1% of PET scans, what we call incidentalomas, and about half of them are malignant. If the iodine 131 scan is negative but the TG levels are elevated, or if there is medullary thyroid cancer, I think the change in management was based on 60 patients in about 9%, but in terms of picking up recurrence, there was a 53% change. Some tumors take up only FDG or iodine 131. So it depends on the degree of differentiation. Well differentiated, higher iodine uptake due to the presence of the sodium iodide importer system. We think that FDG should be included in the standard of care for thyroid cancer. It locates thyroid cancer, especially those which poorly concentrate radioiodine, localizes medullary thyroid cancer with negative localization. And of course there's this flip-flop phenomenon where the better differentiation in fact tells you that there's good iodine uptake. And a few examples: iodine negative but multiple metastases on the PET, iodine positive, PET negative, SESTA MIB positive, iodine also positive, but then after treatment the iodine is still positive but the MIB is still negative. So the MIB can be considered a poor man's PET because the PET is still negative. Again, another patient, high TG, iodine positive, but the MIB is negative after treatment even though the iodine 131 scan is positive. Iodine negative, PET CT positive. Again, another patient, iodine faintly positive, but the PET shows very extensive disease. And the last patient, iodine positive disease, SESTA MIB positive disease, and iodine, PET FDG, a number of positive notes. So with that,